Well, I appreciate the hearing, and I thank you all for your thoughtful observations. I have a question that has to do with this whole issue of interoperability and how advanced we are, what we might be able to achieve in the form of savings. If I twist my knee in Colorado and have to go to the ER, and they want to, find out what prescriptions they can give me and that sort of thing, or how to treat me, and to be able to know who treats me in South Dakota, what my medical history is, that sort of thing. Is that, or for example, now even between you got long-term acute care, you got all these various ways in which people access the healthcare system in this country. How integrated are we? How interoperable are we in terms of electronic medical records and that sort of thing? Say on a scale of 1 to 10, and then how much do you think? What sort of savings could we achieve? And I'm sure that's a very difficult thing to quantify, but if you could at least in general terms talk about what that might mean in terms of avoiding redundancy, avoiding duplication, overutilization because of tests and all sorts of things that might be available if you had access to a medical record for a patient.
Senator, if I may, interoperability is something that is not at a level that it should be. If I was to score it using your 1 to 10, it's probably a 3. It's for two reasons. Number one, it's been a slow adoption of electronic health records and other automated clinical systems. And the groups to my left here are exceptions to the rule. The second, though, is that even when you have integrated systems on electronic systems, trying to move between systems is very poor. And I think it represents a threat to safety as well as an issue around efficiency. How much efficiency and the ability to provide a specific number, I suspect we could come up with some estimates, but certainly in a society that expects choice and is full of mobility, to have a system that silos its information really is countercurrent to their intent.
Let me just give an example. So we have a joint operating committee with the Cleveland Clinic, like I mentioned in my testimony that we have a lot of folks. And we were very focused on rehospitalizations in that joint operating committee. And the number one issue of all those clinicians was how do we get information to manage these patients? And so we built an interface with Epic, which was the clinical information system that the clinic uses. And now the Cleveland Clinic doctors can access Epic, and we've linked it to ProTouch, our medical record. So when they follow the patient from the clinic to our long-term acute care hospital or our subacute facility, they can go backwards into the Epic system, or they can move forward into our system as we built that interface. And that is a 1% on the 10% chart that you said. I mean, it's just not happening fast enough. Okay. And urinary tract infections, rehospitalizations caused by that and other things have dropped by 30, 40% by letting our clinicians have the information to manage patients across these sites of care settings.
Okay. I would just build on that and say that from a getting information to physicians, it's very difficult at this point. One of the major aspects of how we can improve quality and lower cost is through a transitional care program that we have within our organization, trying to make sure that when a patient is discharged from the hospital that we know everything about what happened there, so that as they move into the home environment, we can make sure that we're carrying that care through so that they're not readmitted into the hospital later. I think a big part of this is additional investments into the health information exchange models. In Pennsylvania, there's a project underway, and it's at the state level. It's very complex. It looks like it's going to take some time to get in place. In Delaware to our south, we found that they have the Delaware Health Information Network, which is a backbone of health information that allows physicians and hospitals to sort of plug in and get that information out. But to your question, if something is happening across the country, that information just isn't there. And it really is an issue of patient safety. It's an issue of making sure that you have timely information into the clinician's hands so that they can actually affect change when they need to. we're still a long way from that. I would not even give it a score as high as 3 as my colleague down at the end of the day.
And by and large, that's a resource issue. I mean, it's just to make that, but to create those standards of interoperability, we've always talked about that, but it doesn't sound like that's happening out there. At least, and I guess my last question is, my time's out, but how do we incentivize that?
Well, Senator, right now the incentives are to continue to build infrastructure, and I agree with what my 3 colleagues have said. You know, we're one of the more advanced systems with electronic health records. All of our Chicago area hospitals achieved meaningful use stage 1 last year. We have 4 prime vendors, and while they all meet meaningful use and, quote, are interoperable, unless you set the systems up with the same data definitions in the same fields, you realize that you're talking theory, but in the real world, I can't exchange your prescription from the medical group system to the hospital system, and it creates a host of safety issues. It's much more complicated than banking because you don't just have to deal with 10 digits and putting them in the right boxes. We're moving in that direction. It needs to be encouraged and incented, but ultimately there needs to be standardization of the definition so that when we record a blood count in my office system, it's the same as a blood count in South Dakota or in the hospital so that it moves seamlessly. And that's one of the practical challenges. And to be honest, the vendors don't have an incentive to do that. They want to try to, you know, be a one-brand solution and keep you in their field.